Hello, I'm Dr. John Cruz, and today I'm going to be talking about when will my meds start working, and I'm going to focus that on both antidepressants and ADHD medications. So today's talk is going to be about 20 minutes. If you have questions while I'm talking, you can type them in and I'll get to them at the end. This will also be posted on YouTube and Facebook, so you can reference it later and ask questions there. And usually I start with the takeaway. So from my other talks out there, you know that I'm a big fan of science and looking at this research and studies. But I would say this is one case where the research may constrain our thinking more than it's helpful, or may even lead to misleading conclusions. So that's the takeaway. And I'm going to start with antidepressants first. So with antidepressants, there's two dogmas that I'm going to challenge. One is that antidepressants take 4 to 6 weeks to work. That, if you open up any Psych 101 textbook, that's what it'll say, that it's going to take about a month for them to be working. The other dogma I'll spend less time on is that ketamine, which there's been a lot of attention in the media, a lot of people trying it and using it effectively for depression, but a lot of the push has been ketamine is the only medication to work quickly for depression. Flat out wrong. Getting back to antidepressants, or medications in general, the time course of how quickly they work. The first thing is the medication has to get from outside your body inside your body, and mostly we're talking about oral medications, so absorption is a factor, but the absorption is only going to affect things on the scale of a few minutes to hours. Things pass through your digestive system within a day or two. So even a slowly absorbed medication isn't going to be that meaningfully different on the time scale of days to weeks. And also conversely, whether your stomach's too acidic, whether things pass through quickly, isn't usually a big factor for most of our psychiatric, for antidepressants. They're maybe of more importance for ADD medications where quick onsets on the order of hours is important, but for an antidepressant, absorption plays only a tiny factor. The next issue that lots of people focus on, and I have lots of people say, the Prozac isn't going to work right away because it needs to build up in my body and I need a steady blood level. And that just isn't the case. So many of our psych medications have a half-life of about a day, so many of the conventional tricyclic antidepressants, SSRIs, Prozac is a notable exception here. That's closer to 10 days for both the fluoxetine and its active metabolite, norfluoxetine. But usually medications reach a steady state in your blood, so as much is going in as is being broken down and excreted each day, in about 4 half-lives. And again, with the half-life of many of our drugs on the order of magnitude of a day, usually within 4 or 5 days we have a steady state level. Some drugs may get there more quickly. Some, like Prozac, actually take many weeks to get to a steady state level. And again, the steady state level has almost nothing to do with how these drugs are working. Now with some other drugs, like in some of our antibiotics, you do need a steady level in your blood. You need to be maintaining at least a minimal for it to be disrupting bacterial membranes or blocking viral RNA replication or DNA replication. So their steady state levels, getting to that steady state may be meaningful, not that important for antidepressants. So with antidepressants and also with our other psychiatric medications, these drugs have direct biochemical action, so a serotonin reuptake inhibitor directly, immediately, within minutes to hours of taking it, blocks the reuptake of serotonin, making more serotonin available at the synaptic level. It isn't boosting the serotonin level, it's just making what's there available for a longer time. It's effectively boosting the signal. But if that's all that it took to get free of depression, we'd have SSRIs like Prozac, Paxil, Zoloft would be working instantaneously, and they don't. So our best understanding right now is that for antidepressants and certain other classes of drugs as well, It's their indirect biochemical action that's important. And I often jokingly tell patients that if I knew, we know the direct action of SSRIs, we know with some of our older, messier drugs like tricyclics, we know what their immediate actions are on target systems and on systems we don't particularly want them to be hitting. We know a lot about the neurochemistry, but that's different from knowing which neurochemical actions are actually getting someone free of depression or anxiety. And I jokingly often say if I knew how these worked, I'd have a Nobel Prize. I don't have a Nobel Prize. Right now, we don't have a complete understanding of how they work, but that doesn't mean we know nothing about it. So we have strong bodies of evidence that for antidepressants, certain things are important. So the immediate biochemical action triggers a response in the brain, and one of those responses is making new proteins. We know that new protein synthesis is a important, if not essential, step for many of our antidepressants to work. And making proteins is not an immediate process. You don't just say, okay, start making it and have a vast supply of Also, and probably more importantly in the brain than just making the proteins, is moving the proteins. So most of the manufacturing capability is in the cell bodies, and most of the cell activity for a neuron is exchange at the synaptic level at either end of the axons and dendrites, which are long projections from the body of the neuron. So if we have a little protein that's on the order of nanomoles, say 5 nanomole scale, and it has to get out the cell body and down a axon that's 5 centimeters long, that's actually the equivalent of a human-sized object traveling all the way around the equator of the world. I just did the math a few minutes ago. So we don't appreciate it because it's also small, how big a task that is to move a tiny little protein from the cell body all the way out to the end of the cell terminals. But that takes time, that takes work. In addition to just making proteins, sending them out to cell bodies, connect and changing how nerve cells interact with each other is part of how these antidepressants work. And probably making new cell bodies, which again is not an instantaneous process. So often we compare all these things to an assembly line. And when Mr. Elon Musk started Tesla and started building cars, even though he was getting work orders and immediately coming in the door, getting a work order, getting a signal like boosting your serotonin or blocking the reuptake of serotonin immediately doesn't translate to an immediate production of your car at the assembly line. The whole assembly line has to be geared up. You need the tools, you need the workers, you need the raw material to go into it, and you need time, because even if you have everything in one place, it's going to take time to build up and create the product that you're trying to create. On the other hand, with that, the usefulness of the assembly line model, is that if on Sundays you're not getting any U.S. mail and the work orders cease to come into the Tesla plant, they don't stop making cars. So there isn't an immediate shutdown of this long assembly line process just because you're not getting a consistent signal. It also speaks to why we have robust evidence with all of our antidepressants that the more consistent in the first several weeks you can be. So if you are taking some days, skipping other days, you're telling the brain, hey, start this whole assembly line. Then they'll say, don't bother. Hey, start it up. The brain gets that conflicted message, that inconsistent message, and expends less energy gearing everything up to get going. So we know being as consistent as you can in the first several weeks both decreases the time slightly by which these medications work, and also even decreases the likelihood that they will work if you're inconsistent early on. However, on the other hand, and we don't usually advertise this fact, consistency with taking most antidepressants is not particularly relevant after the first 2 weeks. So you can skip days at a time, and again, it's given the assembly line analogy, it's not shutting down the whole assembly line. Some of our antidepressants do have withdrawal effects, but that's separate from whether they lose their antidepressant efficacy. And it's been studied most extensively with SSRIs that cause sexual side effects, where very clearly drug holidays, again, once you've established and had a good sustained antidepressant action, you can probably miss the drug 2 days a week, take it 5 days a week, and blood levels drop low enough, and the sexual side effects seem directly related to blood levels, whereas again, the antidepressant action is related to indirect, slow, long-term assembly line-like processes. So just getting back to the main question, how long does this take to work? And again, the textbook answer is these antidepressants take a month to start working. The data really suggests, and the clinical experience overwhelmingly suggests, that of those who respond, so there will be people who don't respond, but about half the people who respond know in the first 5 to 15 days things are getting better. So why does that clinical experience not show up as robustly in the data? And I'll get to that one. I'll add one more thing. So half the people who are going to respond are responding in that first week or two. Most people are responding substantially in 2, 3, 4, 5 weeks, but we also know at the other end of that about 15%, and this seems pretty consistent across a whole host of different classes of antidepressants, 15%, so 1 out of 8, 1 out of 6 people who will respond are showing absolutely no measurable signs of response at 4, 5, 6 weeks, but are by 7 or 8 weeks in. So that's the general framing. So why, again, are the studies and recommendations inconsistent with what we're seeing clinically? And there is some research that I'm going to point out. One is how the studies measuring antidepressant, the time course of antidepressant efficacy, are studied. Every time you collect data from people, there's a lot of costs and expense. So a drug manufacturer trying to get its study approved by the FDA to minimize costs is only going to be measuring at a certain few time points. And usually we have a baseline measure. We have 2 weeks in. We may have 4, 6, 8 weeks in, maybe 10 weeks. That's usually 10 to 12 weeks is all you need to get a drug approved for antidepressant efficacy, even though depressive episodes tend to last for months or sometimes even years. So ideally, you'd actually want to have more finely detailed, more data points in the first few weeks to know actually how quickly they work. You'd want to have longer duration. But the FDA sort of adopted standards on what's sort of minimally likely to show that it's working. So further confusing the point, so I've said most studies are collecting data 2 weeks in, but it's often not until 4 weeks in that we're clearly showing these antidepressants are working. So what's happening at week 2? Well, 2 different things are confusing and going on. One is at week 2, many people in the placebo group who haven't gotten active medicine are showing some improvement in their symptoms. Now, there are ways to tease out placebo responses, certainly at a group level, from real biological antidepressant responses. Placebo responses tend to happen more quickly. There's certain other ways to tease it out and rebound at a different time scale. But if you look at the placebo group who didn't get active medicine at 2 weeks, on average, they're doing better. On average, the treatment group's doing better. But the 2 groups aren't separating from each other. So we can't say the medication's really doing something at the time point because both groups are doing better. And there's a separate factor, not just the placebo response going on at week 2. So there's something called regression to the mean. And I've been told not to get into politics, so I'll just note that some people think that regression to the mean is what happened in the US when Trump got elected. I won't comment on whether I agree with that or not, but statistically what regression to the mean means is if you start with a data point that's far away from your average, so if you're starting people with a host of depressive symptoms, with mood that's different from normal, just on average, your next measurement is going to be closer to the average, closer to a standard normal level, than because you're starting from this extreme elevated point. Doesn't mean the next point has to be better, but that regression to the mean means everyone's likely to be a little better than they were at their worst or close to the worst, which is when the study started. So that also obscures the ability to detect improvement in the first 2 weeks. And again, there is some data, and certainly my clinical knowledge would be that half the people who are going to respond are doing it 2 weeks in. So by that first time point, which isn't revealing it because of how the statistics and studies work. So that's my point there. So jumping over to the ketamine and antidepressants, more than 90% of the comments or discussions in the popular literature, newspaper, magazines, pod sites say, ketamine is so wonderful because it's the first antidepressant we have that works instantaneously, that works essentially within minutes to hours, rather than taking 5 to 15 days or 2 to 4 weeks to start working. And that is just flat out wrong. So we have more than 5 decades worth of data on another class of medications that work astonishingly well, strongly pull people out of depression within minutes to hours, just like ketamine does. What are those? Those are the stimulant medications. So there are studies on different forms of Adderall and amphetamine. There are studies on different forms of Ritalin, methylphenidate, that show these have potent, immediate effects pulling people out of depression. Now, why is that getting ignored in all the modern attention? One is that stimulants have never been widespread. We've never seen widespread use of them for depression. The studies certainly aren't as extensive as studies are for a conventional antidepressant to be approved by the FDA. And a large part of that is that the stimulants do have potentially really bad side effects. They're not particularly common, but if you were going to treat millions of people, and millions of people in the US are depressed each year, you'd be affecting lots and lots of people. There's also a question whether it's really a euphoric effect, whether it's just a mood-boosting effect, or whether it's a genuine antidepressant effect that the stimulants have, and particularly with the stimulants effects on mood, that seems to be related to how much drug is in your body at a given time, and as the drug wears off, most people crash. That is different than ketamine. So when ketamine works, the benefits for mood usually last for hours, days, a few weeks, sometimes many weeks after the ketamine is directly out of your system and working. So I'm not saying stimulants work exactly like ketamine. I'm just saying we do have and have had stimulants, antidepressants, that have worked quickly for decades. So jumping over to the stimulant and ADD, sort of how quickly are my meds going to work? What I'm going to object to here is the dogma, and I've seen, and I listen to lectures time after time, where the experts say, stimulants are great, stimulants work immediately, they boost dopamine, they boost norepinephrine within minutes to hours. That's how they help with all the executive function deficits with ADHD. And then they say the other medications, and here I'm not talking about absolutely all, but I'm talking about things like Wellbutrin, like Strattera, atomoxetine, like Cymbalta, like Fetsima, the SS, serotonin, and norepinephrine reuptake inhibitors, which we know clearly, robustly help with ADD. The magnitude of the effect of those drugs is pretty close to the magnitude of the effect for Ritalin, methylphenidate. It's less than for Adderall. And all these experts will say, oh, these are antidepressant drugs or antidepressant-like drugs. Therefore, they work slowly. They work on the course of 2 to 4 weeks to help with ADHD. Why that is just wrong? 2 different reasons. One, it doesn't fit the biochemistry. We know these drugs boost norepinephrine immediately, boost dopamine immediately. We would expect from a scientific level, from a neurochemical level, them to work immediately. And what do you see when you talk to people? I've done it. I've been collecting testimonials. Again, given since it's so discrepant with what the experts are saying. What the people say is, oh, that first day I took Wellbutrin, I could see that it was working for me. I could tell. I was focused. I was doing something differently. Or one of my favorites is I had a patient who took Cymbalta in the office. And when he got downtown, a half hour later to his workplace, he describes a guy on a skateboard coming at him, and usually he knows in a sort of ADD, overwhelmed with too much stimuli coming at him at once, he would have just frozen and stood there. And it was revelatory to him that a half hour after taking the Cymbalta in the office, he could simply step out of the way. So he could see, again, an immediate impact of an norepinephrine boosting agent or reuptake inhibitor on his ADHD symptoms. So why, to put it crudely, do the experts have it so wrong? One big thing, I think, is Strattera. So for years, Strattera was our one non-stimulant that was FDA approved for ADHD, and Strattera, in all the studies used to approve it, and usually clinically as well, is started at very low doses because it has lots of side effects, lots of unpleasantness. People need to take it and titrate up slowly, and it usually takes many, many weeks to get to an effective level. So what we're seeing is not that Strattera takes a long time to work on ADHD. We're seeing that it takes a long time to get to an effective dosing to treat ADHD. Two very different concepts. And usually with Wellbutrin, usually with Cymbalta, usually with Fetsima, you can start at an effective dose the very first day, and side effects may be present but are usually manageable. Second reason why, and a more pervasive and less obvious reason, is how the FDA requires people to do studies for medications for ADHD. If you're studying a stimulant, because the stimulants are expected to work quickly and because they do have some uncommon but really bad side effects, the FDA requires you to do studies, not waiting 2 weeks out for the first data point, but looking a few days in and having multiple time points in that first 2-week period. If you do that, then you have multiple time points, multiple opportunities to tell how that the drug is working quickly. Again, given the cost of all those time points, so the FDA, when testing for ADHD efficacy for a non-stimulant, it does not require time points, data points that quickly for a non-stimulant, because their expectation is it's not going to work that quickly anyway, and the side effects aren't likely to be that bad. So commonly, again, as with the antidepressants, they're not even studying it till 2 weeks in or 4 weeks in. And again, we have that maybe not much difference or not statistical difference from the placebo group at 2 weeks in. So it looks like, these may be taking 4 weeks to differentiate from the placebo group by 4 weeks. But again, that does not comport with what I see clinically. It doesn't make sense or be consistent with the neuroscience. So there are some non-stimulant ADHD medications. Guanfacine is one, Qelbree, which just got approved several months ago. Those may actually take some time to work. So it's not as clear whether it's the immediate biochemical action, again, like boosting norepinephrine or boosting dopamine, that how these two work. It does seem to be more indirect pathways, that the immediate biochemical effects are setting other neurochemical actions into effect in a slower cascade. So it may well be that guanfacine or Qelbree, Intuniv for guanfacine, they may genuinely take a longer time for effect. I'd say, again, how we study the question makes it really hard to know, could some people really have immediate effects? So that's about all I have to say. I hope I went through it in a timely manner. And next week, I'm going to be talking about emotional support dogs for ADHD. I'm not seeing any questions right there, so maybe looks like it says there's one comment. Okay. So the question is, I feel more depressed in winter. Does that mean adjusting doses seasonally would make a difference? Suggestions for maximizing communication between me and my psychiatrist. So a couple different questions here. So certainly depressive seasonal patterns, so a different time scale than just immediate hours or days or weeks, but sort of a seasonal pattern. We know that a large minority of people with depression certainly show seasonal variation, and there's some anecdotal evidence and a tiny bit of research that possibly for these people, increasing the dose during particularly winter months may prevent depression for those people. And then the second, suggestions for maximizing communication between me and my psychiatrist. I'm going to hold on that one for another topic, because I'm not sure how it ties in, and I would say suggestions for maximizing communication would be, if you find yourself losing track of or not making good use of the sessions effectively, it may be writing things down ahead of time. It may be appreciating that only a small subset of questions, if you have many, can be answered in a given time. And it may be that it takes time itself to know the answers or the results of certain interventions that are going. And I almost always advocate only changing one thing at a time so we can know what's really going on. So that's all for today. Have a healthy, happy week, and I will be back next week, which I think will be the last last video from this office I have here in San Francisco. That's all.